Okay, thanks again for staying with us on the program TMI Monday. We'll begin our conversations today on the show by talking health. As you know, health, they say, is wealth. By SDG standard, goal number 3, it is expected by the year 2030 there will be universal health coverage. And some of the things that we see today, some of those illnesses, diseases, infirmities would have been taken care of. For some, one way to fast track and accelerate access to affordable and cheap health care is health insurance. Today's program, we're going to x-ray that and see how feasible, how workable, who is qualified to take such a policy. Against the background that there seems to be some resentment to insurance policy, generally speaking. If you look at those in the insurance industry, particularly as it relates to maybe car, house, and all of this stuff, there seems to be some sort of apathy towards it. So how realistically feasible will this be? I have with me in the studio the Director General of Edo State Health Insurance Commission, Dr. Rock Amego. Doc, thanks for joining me on the program.
Thank you.
Good morning. Well, Happy New Year.
Happy New Year to you and your family.
Thank you. This whole concept of health insurance, what is it about? Give us an insight.
Well, good morning. Thank you for having me on this program. I'm delighted to, put some light into health insurance as the apathy has, grown for a long time.
Okay.
Well, health insurance is the idea of health insurance is that everybody can get health care as long as you pay little amount of premiums into the commission. And then when medical catastrophe occur, you can seek health care from those accredited centers which health insurance is engaged with.
Okay.
Health insurance has started in many countries about 40, 60 years ago, but it was easy for them to go through with it because they had a lot of data. We are just now starting to gather our data, and so we're trying to get tributaries to get most of our data and get into the scheme. Happily, Gordon Obaseki, who has the political will to push this program forward, has been very interested in it, and we're starting with the formal sector plan, which means that the ones that the civil servants are paying, that the state government are paying, will get into the scheme come January end in this month, and then by March, they'll start receiving service from the healthcare providers.
Fantastic. Before now, we heard about the National Health Insurance Policy. Is this a different platform entirely, or there's a meeting point somewhere?
Yes. As with other parastatals in the country, the National Health Insurance Scheme is like a regulatory body for the other state social health insurance scheme, just like the one we have in Edo State, Delta State, and other states of the Federation. Okay. So the National Health Insurance Scheme, as it were, acts as a regulatory body for the state health insurance scheme. You can liken it to the Federal Ministry of Health and the State Ministry of Health. They started a couple of years ago, but the coverage has been very low. And so in the light of that, we try to decentralize it so that you can enroll people in your various states. With the population, you have to decentralize most of this. Edo State, for example, has a population of 4.5 million people. It's very difficult for people in Abuja or Lagos to decide who gets health care when they are not in society to determine, the various modalities or changes or, dynamics that occur in a particular society. So in the light of that, that's why it was decentralized, so that National Health Insurance Scheme can have, various states organizing their health insurance scheme and increasing coverage for the whole nation.
Okay, because the National Health Insurance Policy has been on for a while, I can't recall exactly how many years. What about those who are already established with National Health Insurance Policy? Are they qualified to also enroll in EDOHIS?
Oh yes, certainly. Yes, certainly. What we did when we were drawing policies for Edo State Health Insurance Scheme was that we tried to draw a policy of all-inclusiveness, and then we're also talking about voice, where everybody can participate and bring their idea to the fore in implementing these our processes. National Health Insurance Scheme started about 11 years ago. But sadly, coverage has been very low. Just like I mentioned earlier, a body in Abuja is unable to capture a lot of people in the state. For 11 years, they've had about 3 to 4% coverage. But just now, since the State Health Social Insurance Scheme has been kicked off, some states started about a year ago. I was appointed as the Director General of the state scheme in August last year, and we're kicking off this scheme this year because we have to do a lot of back end. We are hoping that we can get universal health coverage. Our mandate for this scheme in Edo State is that before the year 2024, we should have about 30% coverage, which comes down to about 1 million lives. So we're trying to be as realistic and practical as possible. Yes.
Fantastic. I'm always concerned about policies of this nature, which some say is a bit elitist in nature. Is that correct?
You know, the insurance, as it were, whether health insurance, whether property insurance, you know, it's never straight. It's very, it has a lot of back end, you know, but you can understand it actually. You know, because of the decay we've had over a long period of car, you know, owing to people who have car insurances, and then you go for your claims and then they reject you. People have had apathy towards insurance. Yeah. You know, so in our value chain, all the stakeholders are made to be salesmen. We're telling these people, in fact, we're having an end-to-end ICT platform such that once you're engaged on the scheme, you know what's going to come to you. The laws are there, and so if the scheme, you know, if there are disputes and the scheme that does not meet its mandate, of course, you know, we can resolve in the court or out of court, you know. So everything has been laid down in principle, and then everybody has levels of authorization on the platform. It is not very elitist. Why I say it's not very elitist is that even those who do not have income, those who are not fully participate in society, as it were, because of the unemployment and, you know, various factors, even the disabled are also covered. You know, we draw up a plan that covers everybody. The plan for those who cannot pay is called the equity plan. The federal and state government are supporting this plan, and we plan to register in this year alone about 26,000 people. You know, we can only grow, take little bites, and then grow, take learning curve, and then see where we make mistake, and then improve on our processes. So it's not really an elitist plan. It's just that the consciousness of health insurance is not really there, and so that's why we're trying to propagate it. We're selling it to schools to start teaching it from the basics, and we're putting billboards in various places in the state. We're selling it to market women and even those in the, you know, the health chain, from the cleaners to the doctors to the nurses, you know, and all other MDAs, as it were, to preach the gospel of health insurance. Our traditional rulers are also doing that. So it's an all-inclusive process, sir. It's an all-inclusive process.
Let's talk about how the policy works in terms of its operations. For example, someone wants to take a health insurance policy. What is he supposed to do? Where does the person start from?
Oh, well, thank you. That's the easiest way, and that's the easiest question to ask, because that's the basic. What we did is that, because we wanted to capture everybody in society, we stratified the society into 5. Okay. Like the equity plan I talked about is for those who cannot pay, because nothing is actually free. You know, that's what we've been trying to sell. But, you know, even though the government is covering for it, we have to know that its government is paying for it. It's not free. So the equity plan is covered for those who cannot pay. The informal sector plan, where most of us in society, you know, belong to, about almost 80% of the society belong to, that's also there. Then the formal sector, which are the civil servants, and then of course the students in the tertiary institute. Okay. Yes. So if you look at all these plans, it covers for a family and household. But for an individual who is not a government employee, for example, if you see our billboards, it's been saying 15 naira a day. You can belong to a group, an aggregator group, the ones that locally people call Olidara, or, you know, even the POS merchants who are also selling it for us, and then you pay 50 naira every day. At the end of the month, you'd have paid 1,500, and at the end of the year, you'd have paid 18,000. So the least plan on our health insurance is 18,000 naira per year, and that guarantees you access to free quality healthcare service in our accredited centers. When you pay, we have a 2 months, for lack of better word, moratorium, because we need to do some adverse selection, you know, to know those who are very sick, to know their health, and then, you know, come to a deal as to what to give to them. We also need to use those 2 months to update their profile, allocate healthcare providers to them, and then give them health education as to where they will go to. So it's as easy as that, paying 50 naira daily, getting to 1,500 a month, and 18,000 naira a year. We are trying to develop our ICT platform where those even at home can register from home using USSD. By the end of this month, when the governor has launched it formally, all those codes will be displayed so that people can register from home, and also we also have supporting staff to register people from.
What's your definition of a household within the context of the policy?
Yeah, yes, our household, what we did is that we said household is father, mother, and 4 children less than 18 years of age. Okay. When we're also doing our demographic study, we found out that there was a lot of polygamy in the society. But we couldn't cover for everything because, like I said, all these services are being paid for. So for those who have extra dependents, such that maybe they have 8 children, 7 children, or you have 2 or 3 wives, you have to do a top-up on the plan you've already had to cover for all the other dependents as a principal beneficiary. Yes.
So the 50 naira a day that you talked about, can that also apply
No, the 50 naira a day applies for an individual.
Okay.
So if you're talking of a household that is a father, mother, and 4 children, you have to top up for those people to get up to those premiums.
Now you said you must be less than 18 years old as a child.
Yes.
To fit into this policy. What if you are not more than 18 years old?
No,
as part of the household.
Oh, okay. You can't fit into the program. Like I said when I was describing the various plans we stratify to allow everybody in society fit into.
Yes.
You know, remember I also said that we have a student health plan.
Okay.
So for the student health plan, it takes care of those who are 18 years and above, where they get health services from their institutions.
Okay.
But for those who are less than 18 years of age, with their parents being principal beneficiaries, they can come to healthcare centers to receive healthcare service based on the principal and dependent beneficiaries on the scheme.
Okay. Even with the national health policy, I heard some people talk about, okay, well, there were some complications. Someone, for example, who is pregnant, all right, you probably didn't anticipate that at the point of delivery is going to be through CS. And then you find that somehow the policy doesn't cover such, an eventuality. So what is the scope of this policy in terms of what someone who has taken this policy can benefit in the event of a health challenge? What is the extent? What is the maximum? What is the minimum?
To tell you the maximum and the minimum would be a little bit difficult because there are various illnesses. But maybe this can answer your question. Malaria, for example, in society is everywhere in our country because we live in the tropics. It's one of the most recorded illnesses in society. So on our health scheme, malaria is covered for everyone, for example. Also talking about CS that you talked of when one woman was pregnant, usually maternal mortality is like a temperature guide for any health indices in the society. So that's also covered in the primary care. We thought about this, and then so we put various health illnesses that are very common in our environment in primary care, and those which are not very serious that you don't encounter daily, put it on our secondary care where we have to seek specialists to do that. And like I told you, 85% of our hospitals that we have engaged are primary care. So for a woman who doesn't anticipate giving birth by CS and is under the health insurance scheme and gives birth by CS, she will not pay a dime. She will be taken care of as long as she is engaged into the health insurance scheme. That's what we've done in our scheme. We are already doing that, for example, in the state, but it's not reflecting. Our maternal mortality, for example, in those states has reduced, but it's not reflecting nationally because other states have not been able to get at par with us. So with this health insurance scheme, we're hoping that that will further reduce, and then it can translate nationally, doing the average in all 36 states eventually after we run for a couple of months or years to come.
If you just join us, it's TMI Monday, and I've been talking with the Director General of Edo State Health Insurance Commission, Dr. Rock Amego, sharing some insights with us on the challenge of access to affordable health care and checkmating that using an appropriate health insurance policy. We're looking at this against the background that over the years there seems to have been some sort of apathy towards insurance policies, but particularly whether it's for a car, whether it's for your house and stuff like that. Using that as a basis for this conversation, how sustainable is this in terms of the projections that you have?
When we started, one of the first things that His Excellency wanted us to do was that he wanted us to do an actuary study. An actuary study is calculating how much it costs to give any health plan to any individual. So the companies that came, they did a data utilization dating back 4 years before, went to private and public hospitals and did a mean of the cost. And so we were able to agree with a price where most healthcare providers will agree to. So using this scheme, when a healthcare provider is registered on the scheme, he automatically knows the amount of money coming to him. Yeah? And so because I told you that on our value chain, every stakeholder is a salesman, we hope that we are going to start improving the numbers. As it were today, all the civil servants, because the state government is paying them, are automatically just going to migrate into the health insurance scheme. But remember I told you that the informal sector, where the population lies. So every stakeholder on our value chain is a salesman. So everybody's going to try to, we have KPIs to meet, sell this health insurance scheme, and then if we're able to meet our target, like I told you, practically in the next 3 years, 1 million people, I think that's already sustainable. That you are not going to say 1 million lives don't matter to any particular government, whether it be PDP or APC. Any government that comes and sees that 1 million of its population is getting good benefit as to quality healthcare, of course it will want to increase political will in the program and make it drive and ensure universal health coverage, just like WHO has proposed.
Okay, fantastic. Let's look at the service providers. I don't know if that's what you call it, but we're looking at the hospitals that will be involved. Are they strictly government hospitals, or you have private hospitals involved? Because how are you guys going to work through this challenge of where some of these service providers, they collect premium, they don't remit, and that seems to be a clog in the wheel of progress where those who've taken insurance policies, they're not able to get what they want.
Yeah, we try to put checks and balances to most of these challenges that many insurance claims have had all over the world. One of the very interesting things that we've done in those states is that we have a health management system which every healthcare provider engaged in insurance scheme is going to use. It's like a software, it's like a platform, be it private or be it public. But today, because healthcare provision in those states is giving about 60 or 70% of private care providers are giving healthcare. Also, we did that, knowing the purchasing power. We use that to put it in tandem in terms of the private care facilities we're engaging. On our scheme today, we have more private care facilities than the government facilities, for example. But the government facilities are going to start being at par. The government facilities, a lot of them are in the state, but personnel has been a problem, and then because of the years of decay, like we have said. So, as an insurance scheme, the first thing you should do is that you should build trust in the minds of the people because of the apathy that has gone down over the decades. And so, that's why we're using ICT as an enabler, so that our process will be transparent. People in their homes can see what we are doing. They can see how many lives are allocated to them. A healthcare provider who knows, for example, that he needs to give service to his people and is not giving service to his people, he knows that he's going to be delisted. And so all the benefits coming to him in terms of loan, in terms of remission, is not going to come to him. So what we are telling the people is that insurance scheme is a win-win situation for the patient, for the provider, and for the commission. As long as everybody on the value chain is doing what they're supposed to do with the checks and balances we are put in place, we are very confident that this insurance scheme will be sustainable. And even after my tenure, it will grow. We can only grow, my brother. That's what I feel in the insurance scheme. Yes.
All right. I'd like to get your perspectives because one of the major health challenges globally now is COVID-19 pandemic. Isn't that a source of concern in terms of the workability of this plan?
Yes, COVID-19 is a concern, it's a challenge in every sphere, be it health, be it economics, be it social. What we've done because of COVID-19, we've deployed the technology on our ECLAT platform called telemedicine, where you can talk to healthcare providers, even in remote places. You don't have to be there. And though in cases where that doesn't meet the patient's demand, it would have to come to the hospital, engaging in all those precautionary measures that government has put in place for COVID. As it were, today, anybody that goes to a hospital before you are treated, a lot of things are done. We check your oxygen saturation. For those who have rapid tests, you check them before they are treated. And so all those measures are put in place. We would have to also check them before they are treated to break the chain of transmission and the spread of this COVID-19. So the insurance scheme has thought about that. So that's why we thought about putting telemedicine and putting all these tests, hand washing, and of course social distancing that we're still practicing. Eventually, when COVID-19 goes and insurance scheme kicks off, every health indices will come into place, every health factor will come into play and merge, and then of course we'll grow and grow and grow, and of course get to these 1 million lives that we're trying to cover in the year 2024.
What's your take on sustainability against the background of the funding? Because we know that health is very, very challenging, even though efforts have been made to have some sort of backup, but funding is always a challenge when it comes to the issue of health. Then again, you look at the people who dwell in the rural areas. How are we factoring this into this whole program?
Yes, funding is a major source of problem for every health sector. What we have done, again, I'll take you back to when I was stratifying the society into the various plans. For the formal sector, for example, they are contributing a percentage of their salary, their gross salary, 1.75% of their gross salary. and the government is contributing another 1.75% of their gross salary, making it about 3.5% of their salary contributed into the health insurance scheme to buy healthcare service for them. So on the formal sector, if all actors meet what they are supposed to meet, healthcare will be provided for them. Now, in the informal sector, where the society is largely placed, those people would have to pay for their services. Either the company decides to take full coverage, or they pay in part. And then for those in the rural society, like we talked about, federal government and state government have been putting resources together. In 2018, they put a budget for reaching out to equity people of about 55 billion, but no state was able to access that. In 2019, they reduced it to 40 billion, and of course in 2020 it was 20 billion. The 2019 budget that the federal government put aside for the vulnerable people, no state still hasn't been able to access it because of the technicalities of the TSA account. Those states, we got about 300 million, which will cover for about 25,000 people. So as we speak, the National Safety Net and the Social Investment Programs, in conjunction with the Health Insurance Commission, is going to various local governments to register these people. Remember, I told you in the beginning of the program that we're trying to cover 25,000 lives. It is upon this precept that the state government and the federal government has contributed this amount of money. You know, once we enroll them, then we've given evidence that we've enrolled them. This money from TSA account will now be sent straight to the subscribers, not even the health insurance. Okay. So it goes from the TSA account, in that for the federal and state government control, to the subscribers. Why I said that this year we are trying to cover about 25,000 lives. Like I said also in the beginning, health is being paid for. So everything is capped. It is not infinitesimal. It cannot go on forever. So with this kind of amount that the federal government has put aside, you say you now calculate how many people you can cover on that, and on that basis you select them per ward or per disease burden in a particular society, or to the areas where health is really needed. You know? So that's what we are doing now. And with that division, we got about 120 people per ward that is going to go around all the local governments and all the wards, covering for about those 25,000 people that the federal and state government have put money together to cover in this year 2021.
Okay, every now and then, as a station, we are inundated with people who come for seeking for one assistance or the other for a health challenge. It could be kidney failure, it could be a heart challenge, maybe there's a hole in the heart, all kinds of health challenges. How do such people take advantage of such an opportunity like the insurance, health insurance policy?
Yes, thank you very much for that question. You know, being a social and an economic investment program, I mean the state social health insurance, we try to meet the needs of a lot of people that have a lot of medical burden. When we're talking about, you know, selecting people into the insurance scheme, one of the things I said was that when people come to register into the insurance scheme, we come to an agreement. We talk to these people, you know, by preventing adverse selection. You know, they need to give us a full detail of their health history, you know, and then by so doing, it puts us in a better position to say what we can give them, what strategic purchasing we can give them with the least amount of money we have. Say, for example, one of our health plans is called the Enhanced Plan. It costs about 74,000, but we give 2 sessions of dialysis. A session of dialysis is 30,000, so 2 sessions is already 60,000. It means that that's over. But because we have, you know, put that in our plan, and we've calculated the risk as to how many people can be on it, as long as you come to us with your health history, we know how to, you know, do strategic purchasing to reduce that amount of money. You know, remember we also said we have a pool, so we can do some cross-subsidization for another plan to help those kind of people. As long as we're able to come to a compromise to say what health challenges you have and how the commission can help, of course some of those people can be accommodated. You know, and those who cannot be accommodated, of course we can escalate to, you know, philanthropists, our government, and, you know, other well-meaning individuals in the country. And of course, if the health insurance has a lot of reserves that you've gathered over the years, of course, what we're trying to do is to improve the health indices of the society. We come through for them and get them to their optimal state of health where they can become participatory in the society again.
Thank you very much, Dr. Amego. It's been nice talking with you.
Thank you,
particularly some of the beautiful insights that you brought to bear on how we can access affordable health care using the platform of health insurance policy like Edo Health Insurance Policy. Thank you so much for coming.
Thank you very much, sir. Thank you.
Okay, it's been a beautiful chat with Dr. Rock Amego, who is the Director General of Edo State Health Insurance Commission, giving us information about the policy and how you can get involved and be part of it, just to ensure that the actualization of universal health coverage by the year 2030 is a reality. Health is wealth, you know that too well, but if you don't have information on how you can access it, It could just be a huge challenge that could distract you, incapacitate you, and make it particularly difficult for you to actualize your dream. It's a brand new year, 2021, and we're in the month of January. Hearing this kind of information is something that you should take advantage of so you can be on a pathway to a great year ahead, even though we know COVID-19 is a huge, huge threat. Doc, thanks again for coming on the program.
Thank you for having me.